Welcome everyone to one of our Lunch, Learn, Link seminars for 2015-16 academic year. This is a new room for us, so hopefully all of you online are getting a good image. If not, remember that we are recording the session, so you'll be able to view it later from the website. This seminar is sponsored by the Sidney Kimmel Comprehensive Cancer Center, the Maryland Cigarette Restitution Fund, and it's co-sponsored today by the Cancer Outcomes and Health Services Research Group here at Johns Hopkins. And today we have a special guest who is interested in patient outcomes. She has a longer title and a bigger topic, but I think what's really attractive about this talk is the fact that it addresses needs that have been identified by patients. And so I think you'll find this very interesting. Rebecca Alexson is an associate professor in the School of Medicine and a member of the Division of Adult Critical Care Medicine and Surgical Intensive Care. And obviously she has an interest in cancer, so we welcome Rebecca today. Thanks so much.
Thank you. It's such an honor to be able to give this talk. So first off too, when I put the slides together, I thought, oh my gosh, what was I thinking? That's the longest title on the planet. I didn't mean it such. I even couldn't put my credentials on because it's so long. But really what I'm going to be getting at is integrating palliative care, perioperative care, and patient-centered research, specifically in cancer-related surgery. And I'm going to talk a little bit about palliative care as well as about a research project that we have ongoing. And kind of who am I and why can I talk about this? Well, I'm a critical care anesthesiologist and palliative care doctor, so I'm triple boarded in anesthesia, critical care, and palliative care. I'm primarily a researcher. All my research is in ways to improve delivery of palliative care, particularly to perioperative, critically ill, minority, and cancer populations. And those are not mutually exclusive categories. A lot of my projects cross all those categories. And as far as clinically, I spend about half my time as an adult intensivist, taking care of critically ill patients in our surgical intensive care units at the Johns Hopkins Hospital, as well as about half my time as a palliative care clinician, caring for patients yet again at the Johns Hopkins Hospital. And I'm also faculty at the School of Public Health. I'm in the Division of Oncology because most of my research is in cancer populations, particularly in the Division of Cancer Prevention and Control. And I'm also a core member of the Armstrong Institute for Patient Safety and Quality. So no financial disclosures, I'm not going to reference anything crazy. My grant support for myself or projects that I've done has been from these organizations, and I'm very grateful to them. And let me start off with just a little bit, let me start with something that finishes usually at the end, but I'm going to put it at the beginning. So do people know who this is? Meryl Streep, of course. So when she accepted the Oscar in 2012, for playing Margaret Thatcher in The Iron Lady, she said, first, I'm going to thank Don is her husband, because when you thank your husband at the end of the speech, they play him out with the music, and I want him to know that everything I value most in our lives, you've given me. And I would say if Meryl was a researcher, particularly a palliative care researcher, she might say this. First, I'm going to thank my mentor, because when you thank your mentor at the end of the speech, they play him out with the music, and I want him to know that everything I understand and hold dear about palliative care, you've exemplified for me. And so I want to thank Tom Smith, who people say, you're an associate professor, you have mentors. We all have mentors, and we have mentors throughout our whole career. Tom is still very much my mentor, and he's an oncologist and palliative care doc here at Hopkins. So big thank you to Tom. I'm starting with it so that I don't rush through that at the end. So at the conclusion of the talk, I want you to be able to talk about barriers and opportunities for palliative care and advanced care planning, specifically in oncologic care as well as in perioperative oncologic care, because I'm a perioperative provider. I'm really interested in people around the time of surgery. And I'll just start a little bit, because I get this all the time, you know, kind of, you're an anesthesiologist, you're an ICU doctor, wait, you do cancer research, how does that happen? So just a little backstory. So I did do anesthesia residency at Mass General, and then came to Johns Hopkins for critical care fellowship and worked with Peter Pronovost and said, Peter, I'm really interested in communication and families and long-stay ICU patients, and I happen to work in the cancer center ICU most of the time. And so Peter then put me in touch with Judy Nelson, who was at Mount Sinai at the time, who's now at Memorial Sloan Kettering, and Randy Curtis, who's at the University of Washington, who are both absolute preeminent researchers when it comes to ICU-based palliative care. And so people say, well, how did you get involved with palliative care? You started out in communications. Well, you spend time with Judy and Randy and you end up in palliative care. And then too, I met Jeff Dunn, who at the time was the head of the Surgical Palliative Care Task Force for the American College of Surgeons. And I said, Jeff, I'm really interested in communication and supporting long-stay ICU patients and families. And he said, Rebecca, you're interested in palliative care. And I said, no, Jeff, more than end-of-life care. I'm interested in more. And he said, Rebecca, that is palliative care. And as many things in life, Jeff was right. And then in 2011, Tom Smith came to Hopkins, and he and I have collaborated on projects pretty much ever since. I've worked with a number of different people in cancer research and outside of it, as well as at the School of Public Health and other places. Eventually, so when I did do my PhD, it was in palliative care, and it was in the ICU, and it was particularly in our cancer center ICU. So that's how an anesthesiologist and an ICU doctor became a cancer researcher and a palliative care researcher and doctor. So when it comes to my research, it's really bridges these fields: critical care research, palliative care research, perioperative research, patient-centered outcomes research. And I have lots of projects in different areas, and they cross the areas. And whether it was divine providence or not, nearly all of my research is in cancer patients and their families. So pretty much every project I'm in it's predominantly involves cancer patients. So a little bit, I'm going to spend about a third of my time talking about what is palliative care, because there's still a lot of misunderstanding about what it is. So in 2011, the Center to Advance Palliative Care did a public opinion survey asking kind of what is palliative care? What do you think of when you hear the term palliative care? Well, they asked doctors and nurses, and when they heard the term, they think, well, game over, the patient's dying, something too about that little frog letting go, something about letting go, giving up. And palliative care providers, like, woohoo, the palliative care team's on the floor, yay, I'm so glad they're here to consult. When I'm a palliative care clinician, I try to leave like my sickle and my hood at home, because it's very, very hot in the hospital. It's hard to carry it around too. But when they asked patients and families what they thought, they pretty much got this. To be specific, about 70% said they're not at all knowledgeable. They don't know what palliative care is. 8% said don't know. I'm not quite sure what the difference is between don't know and not at all knowledgeable, because it sounds like you don't know. Only 14% were somewhat knowledgeable, and less than 10% said they knew what it was. So I still get a lot of folks who say, well, I don't want to involve palliative care. I don't want to give patients and families that message. That message being the whole death and dying thing that you saw was understood by clinicians. And one of the things I say is, you're not giving them any message, because they don't know who I am, usually. And I usually start most clinical consults, and I'll say, you know, your doctor and nurse team asked me to combine from palliative care. When different people hear that term, they think of different things. What is your experience? What's your understanding? And more times than not, I get patients and families going, I have no idea what that is. So while it may change, and I hope it does change, because palliative care I hope gets more integrated in medical care and people know what it is, at least right now it's still a bit of an unknown to most patients and families. So what is it? Well, this is the definition from the Center to Advance Palliative Care. It is specialized medical care for people with serious illness. This type of care is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. Like pediatrics, we're one of the few specialties that does a lot of family-related outcomes. Palliative care is provided by a team of doctors, nurses, and other specialists who work with the patient's other doctors to provide an extra layer of support. Palliative care is appropriate at any age and at any stage in a serious illness, and can be provided together with curative treatment. And for those of you who are knowledgeable about cancer research, palliative care has been part of cancer research for a number of years now. There are specific funding mechanisms within the American Cancer Society for palliative care research. And when I go to national palliative care related meetings, I always feel like most of the folks there fall into three categories. They either are geriatrics clinicians, they are hospice-related clinicians, or they're oncologists and oncology clinicians. It's really one of the core groups for palliative care. And there's a lot of conflation between palliative care and hospice, so I want to just put it all out there right now. So, differences. So palliative care is based on need, not on a diagnosis or a prognosis. Hospice is specifically on a prognosis. To qualify for hospice, folks have to have, at least now with the way current regulations are, 2 clinicians signing that the patient has less than 6 months left to live. Palliative care, anytime, any place, any diagnosis, any prognosis. It's just based on need. Palliative care can be provided together with any other care, and usually, as we've said, the palliative care team works as an extra layer of support with the patient's other clinicians, versus hospice, where really it's often an exchange, and the hospice team provides most of the care. And yet again, palliative care can be provided as well. It can be provided what's called integrative or primary by a primary team, like an oncologist or an ICU team or a geriatrician. It also can be provided as a consultation by a specialized team, like with somebody like myself, or some mixed model. In fact, I mean, I know ICU-based palliative care very well, and most ICU-based palliative care is a mixed model, where the ICU team provides basic palliative care and then consults specialist palliative care folks for patients with refractory symptoms or complex families and dynamics. So, clearer? Good. No more conflation? Awesome. If I've done nothing else today than that, I've lived well today. So palliative care versus end-of-life care. Yet again, conflation. I gotta say, I find the term end-of-life care not helpful at all. Because is it end-of-life care if we don't believe or want the patient to die? If I've taken care of a patient in the ICU for a month and I really didn't think they were gonna die and they suddenly die, I was providing end-of-life care for that month, even though I didn't know it. So the term, I think, is useful retrospectively, and it's actually, when you look at multiple populations, particularly, I mean, I know the ICU well, when you look at patients who die in the ICU versus those who don't, the discrimination retrospectively is pretty different. You can see the 2 populations look different, but when it comes to prospective prognosis, that one patient in front of me, are they gonna live or are they gonna die? Even with the best prognostic models, about 70% accuracy, so still pretty shoddy. So this term is useful retrospectively, but it's not useful prospectively because we're still not good, and I don't expect us ever to be very good at saying exactly which patient is going to die. So when to do palliative care? So this is an old model that said, you know, care, go, 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 oh, can't do it, flip palliative care, as if they're mutually exclusive. And that's pretty much been discarded because when the flip happens is usually much later than would be a benefit to the patient and the family. And curative and restorative care at the expense of palliative care can lead to undue suffering in patients where it is unlikely that they will be cured. And then there's this model where you can say, okay, we'll mix the 2, a little bit of curative, a little bit of palliative care. But the thing I don't like is this is a net sum zero, as if doing palliative care somehow takes away from curative or restorative care. So yeah, yet again, no. This is the model that's forwarded by most groups now, which is saying you should be doing curative, restorative care, and palliative care concurrently, with the proportion or the amount of each increasing or decreasing depending on the patient's needs and the family's needs. And yet again, trying to involve hospice, because multiple measures show that patients who die in hospice die better, with more of their symptoms controlled, and oftentimes in the place of their choice. So trying to get hospice involved. Preferentially, the ideal time is about a month to 2 months before patients die, and that care should then continue beyond the patient's death, because you still need bereavement care for the family. And you can say, gosh, well, Rebecca, that previous diagram, that was like 10 years old. Well, here you go. You want more recent? This is from last year's Institute of Medicine report, Dying in America. And yet again, they say there should be complementary care and quality of life and comfort, family support, healthcare staff support, because it's hard taking care of these patients, not just patients and families who need support, but also the caregivers who care for them. And that you can have cure-seeking care, you can have life-extending care, and then you can have quality and family support care. And I would say those 3, which should be there from the start and continue all the way through, that's palliative care. So evidence for the benefits, well, this was a very nice review that was done, gosh, it's hard to believe, almost 2 years ago now, in New England Journal of Medicine, that was specifically in randomized controlled trials of palliative care in cancer populations. And I'm going to pull out one study, which is the Jennifer Temmel study from the New England Journal of Medicine that was published in August of 2010. This was a randomized controlled trial in an academic tertiary care center of patients who had newly diagnosed non-small cell lung cancer. There were 151 patients, 74 randomized to the control group, 77 to the intervention, and they were randomized to either standard curative treatment or standard curative treatment with proactive palliative care. And it was powered on quality of life, and they showed a statistically significant improvement in quality of life with proactive palliative care. This is across 2 different measures of quality of life. They also found less anxiety and depression in patients with the proactive palliative care. Yet again, HADS, hospital anxiety and depression score, the depression index, as well as the anxiety index, as well as PHQ-9, which is another measure of depression. And you can see markedly statistically significant differences for the group with proactive palliative care. And then the ringer, the reason why Jennifer Tennell was on NPR and CBS and lots of different national news sources was because the palliative care patients also lived longer, statistically significantly lived longer by about 3 months. So folks could say, gosh, well, maybe that was just one trial, I don't know. Well, there's actually now 7 RCTs that show proactive palliative care actually improves survival in a number of different patient populations, including cancer populations as well as multiple sclerosis and respiratory illness. 3 RCTs that show equal survival and none that show worse survival. So when you're thinking about the preconceptions about palliative care and that it's related to death, that's not drawn out by the data. If anything, palliative care proactively is improving survival. Folks say, well, what about hope? Well, I don't want to involve palliative care. It's going to take away hope. I don't want to, yet again, give that message to people. Well, this is some of Tom Smith's data where they looked at patients before and after palliative care, and this was a palliative care approach to telling folks that they weren't going to qualify for their 3rd line of chemotherapy and that it wasn't going to be offered. So in other words, this was a conversation saying, I'm sorry, I wish things were different, but your cancer is terminal, you're going to be dying from this, most likely. You know, what do you want the end of your life to be like? So one could say, gosh, but hope, that would take away so much hope. But at least with the study here, no decrease in hope, and actually there was a statistically significant increase, hard to believe afterwards. And when they did further research on this, patients and families had said, you know, it's better to know than to not know, because you can plan, So why involve palliative care? Why do you want to do this besides maybe the little survival benefit that we saw? But gosh, to improve patient symptoms, pretty much any trial I could pull a dozen that show that anytime you involve palliative care proactively, symptom scores improve. Pain, nausea, depression, anxiety. I always laugh. I always ask as a palliative care provider about constipation, and people think I just have this intense interest in bowels. But you know, we say you're not pooping well, you don't feel well, and feeling well is really important. So I'm going to ask about your poop, and I'm going to ask about it every day. So, and then to improve family symptoms, this is actually a trial from the ICU from a multi-center RCT in a French group that looked at proactive palliative care in the ICU and showed statistically significant improvement in anxiety, depression, and PTSD scores of family members who had a loved one who died in the ICU with improvement with proactive palliative care approach. And the good news is it happens to cost less, pretty much any trial that looks at it. So yet again, this is some of Tom Smith's words that I think are very appropriate. Palliative care equals better care, and it's at a cost we can afford. And so this really gets into a lot of my own research work, which is how do we integrate palliative and perioperative care? Because a lot of folks say, palliative care on the OR, perioperative, like, woo, Wild West. You know, this is something that's really not done. There's a lot of reasons why maybe it's not done, and that's a conversation for another talk on another day, because it's very interesting when you look at perioperative and surgical culture and end-of-life care and why the two have had trouble mixing in the past and even currently. But yet again, beyond the scope of this talk, but another talk for another day. So some of the preliminary data that we had for this work was we did a 2-year qualitative study with long-stay surgical ICU patients and their family members. Yet again, my favorite cancer center ICU that I worked heavily in for this study, as well as a couple other ones. And we interviewed these long-stay ICU patients. Many of them were too sick to be able to talk to us, but we talked to a lot of their family members. And we tried to talk to them and their family members, not only in the ICU, but 6 months and 12 months following their ICU visit, because we wanted to know what was that like for them. We talked to their surgeons, we talked to their SICU nurses, we talked to their ICU doctors. We really were trying to understand the whole experience of that person in the ICU and their family and what it was like to be there, specifically related to palliative care issues. And here's a sample quotation that really gets at the heart of what we found and what we heard again and again. This is the spouse of a patient who had had a major cancer surgery that unfortunately she had developed a perioperative stroke. massive perioperative stroke. We chose Hopkins because we think it's the best. I think they've done everything they can, and basically what they're saying now is that they've done everything. I brought in a woman who was vital, and now she can't speak. It took 9 hours. They took half her insides out, and now she's completely dependent. Can't do anything anymore. She can't communicate. Of all the things we expected, this is not one of them. They went down all the list of all the problems you could have. We didn't think this was on the list. And as my underline of all the things we expected, this is not one of them. We heard that again and again and again from family members. We heard it from them in the ICU. We heard it from them 6 months after. We heard it from them 12 months after. They pretty much think that when their loved one's going in for surgery, the surgery's either going to go well, and as promised, they're going to be in the hospital for a while, maybe rehab, but recover slowly and such. Or if it goes badly, they're going to die on the operating room table. And as a perioperative provider, anesthesiologist, ICU doctor, let me say that almost no one dies on the operating room table. If people die around the time of surgery, it's usually in the intensive care unit afterwards. And so that was very different than what a lot of family members had expected. And this really drew us in as a research question, because not that we could say, how could we help family members to expect this, because it's still uncommon. These surgeries, yet again, about a 2–3% perioperative mortality, about a 10% to 20% perioperative morbidity. So still, the majority of the people undergoing these surgeries are actually going to get through the surgery. But for those people who don't get through the surgery, or who get through with a lot of problems and a lot of exchanges related to their quality of life, how do we better help them somewhat mentally prepare for that without freaking out everybody else? So this really gets into advanced care planning. How might we do advanced care planning prior to major surgery? So we started off with the literature. There'd actually been only 2 trials of perioperative or preoperative advanced care planning. One was in just a general perioperative population of patients who were going in for surgery that involved at least a 1-night hospital stay, and the others were in cardiac surgery patients. And in the Grimaldo study, 200 patients randomized. They did show an increase with a small discussion by the anesthesiologist prior to surgery related to advanced care planning. They showed an increase in patient surrogate end-of-life care discussions. And Song trial showed, she had 32 diets randomized, and she showed that a preoperative advanced care planning conversation, yet again, decreased patient decisional conflict and increased patient and family congruence. But this was it. This is it. This is the literature. You ready? Literature. All it is. There it is. 2 papers. So we then went to PCORI, the Patient-Centered Outcomes Research Institute, and we said we'd like to develop and test a patient and family-centered advanced care planning tool for patients and families preparing for high-risk cancer surgery. Because yet again, a lot of the patients I study have cancer, and we specifically targeted cancer surgery, and we, at the beginning, specifically targeted pancreatic cancer surgery, because this is Johns Hopkins, and we do a lot of pancreatic cancer surgery. So we were a team of patients, family members, surgeons, intensivists, nurses, palliative care providers, quality experts, and woohoo! They said, we believe in what you're doing, and they supported us with a $1.5 million contract that started in July of 2013 and continues to next June. So you could say, oh, wow, you got a grant, you got $1.5 million. Let's go make a video. I know, it'll be great. It's just film tomorrow. No. PCORI wouldn't have given us the money if that was our plan. So we actually spent the first almost 2 years of the grant figuring out what should be in that video. So we started off with an extensive environmental scan of advanced care planning decision aids. And so we really wanted to figure out what is out there. What is out there? Because we don't want to recreate any wheels. We want to build on anything, especially anything data-driven, or things that have very good appeal to patients and families and other stakeholders. Because we said pretty much from the start, our stakeholders are patients, family members, surgeons. If surgeons don't like what we're doing, it's never going to take hold and it's never going to be disseminated. So from the start, we have got very, very close ties to our surgeon stakeholders, including our surgeon co-investigator on the project. And palliative care clinicians, yet again, it's got to have some palliative care in it, and also ICU doctors, because yet again, when these patients do badly, they end up in the ICU. So we had a conceptual approach saying, okay, there's written data sources, there's verbal data sources, because as everybody knows, there's things that everyone knows but aren't written anywhere. And there's professional perspectives. There's what, doctors and researchers and nurses and experts say. And then there's also lay perspective, and both are really important for what we're doing. So those 4 boxes, we spent 2 years filling those 4 boxes. So we did do the systematic review. This just came out a few months ago. And big surprise, we looked at all the advanced care planning aids. We looked at instrument-based advanced care planning aids, which is a video or paper or web, something that's not conversation-based. So we divide advanced care planning aids into 2 groups, conversation-based, instrument-based. Conversation-based would be like respecting choices, where I say, okay, Norma, I'm going to train you to go do advanced care planning discussions with patients and families. For 2 reasons that wasn't very popular with us and with PCORI. One is that it's hard to disseminate that. You have to train a whole bunch of people, and it's hard to maintain a project like that because yet again, you have to train and keep a bunch of people trained. The second thing is surgeons were not excited about it. They did not like the idea of somebody else going and having these conversations with their patients and families. And so being responsive to that, we then went with the instrument-based approach. Because yet again, an instrument, a video, paper, web, that's easily disseminatable. And surgeons very much on board because they said, I can watch the video. I know exactly what patients and families, my patients and their families are going to see. And I'm comfortable with that. So yet again, instrument-based approach. We found over 30 different studies that related to advanced care planning instruments. Absolutely none, zip, 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 zilch, in perioperative populations. However, we did find that over half were in ambulatory older adult populations, with a subset that were specifically in cancer populations. So yet again, though not in perioperative populations, these were groups that look and smell and pretty similar to the groups we were interested in. So we still thought there were good things to get from that. We did an extensive gray literature search. We had Rita Moldovan, who is a clinical nurse specialist, who spent essentially a month with an abstraction tool and all these websites, because she wanted to go see, and we wanted to see if I was my grandmother or my mother going to look at the AARP website and wanted to see what they had on advanced care planning, what would they find? What's on the National Quality Forum website? What does the National Palliative Care Research Center have related to advanced care planning? We wanted to know what actual patients and families, if they went to look on these subjects, what they would find. And we collected everything that we found. And I'll get to that later. We also did key informant interviews, where we interviewed either prominent surgeons who liked advanced care planning, surgeons who did not like advanced care planning, palliative care experts, patient advocacy experts, specifically related to the groups that develop decision aids and decision support tools and such. And so we interviewed them about what they thought should be in a perioperative advanced care planning aid. And we did lots and lots of engagement with our stakeholders. Our stakeholders being, yet again, patients, family members, surgeons, ICU doctors, and palliative care clinicians. So we had 2 different stakeholder summits. And if you haven't gotten the idea yet, let me back it up 2 seconds here. So here's one of our first papers. This work, big surprise, highly transdisciplinary. So you can see I'm the lead author here. Ann Schuster was our research assistant at the time. Judy Miller is our lead patient family advocate. Matt Weiss is a surgeon. Angela Volandis is a hospitalist, actually, who's a specialist in video-based advanced care planning. And John Bridges is a healthcare economist and patient-centered outcomes researcher. So this kind of work is very, very transdisciplinary. Yet again, when you look at the authors here, Catalina Suarez Cuervo is a health services researcher. Rita Moldovan, a palliative care nurse. Fabian Johnston, a surgeon. So yet again, very diverse groups. And such it was at our retreats, at our stakeholder summits with surgeons and palliative care docs and patients and families. We had them look at the first stakeholder summit at everything. Well, we selected, but they looked at a big selection of paper-based advanced care planning aids. They looked at the prominent web-based advanced care planning aid. They looked at videos. We were saying we're going to pop popcorn. We had a film festival in the afternoon where we watched, I forget how many videos. And we had folks talk and tell us and use design thinking with Post-its about what they liked, what they didn't like, what they liked about the content of videos, what they didn't like about the content, what they liked about the style, what they didn't like about the style. And lots of conversations, and we did a lot of listening. And these are some of the things that we found. Content-wise, people liked vignettes, they liked real stories, they did not like things about death and dying. They wanted more the focus to be about how you want to live. And they said it really should be specific to surgery populations, that you can't pawn off, in a dementia advanced care planning tool and think it's going to fly with surgery populations. Style, they liked upbeat, they liked ones that involved younger and older subjects, not just older subjects, and they wanted multiple ethnicities because we came to see really quick that a lot of the videos involved predominantly white, predominantly older adult populations. And the folks that we talked with said, that doesn't represent the population that I take care of, and there are far more people who need advanced care planning than that. And the videos they liked best, the ones they really liked best, were the ones we pulled off of YouTube. So we said, this YouTube, we should go take a look. So we did a systematic review. The journal wouldn't let us call it a systematic review because they said there are no guidelines exist for what would be a systematic review of YouTube. We showed them there had been one paper published before that had done a systematic review of YouTube, but they still made us call it a review rather than a systematic review. But it was a full-on systematic review. So we had 23,000 hits, about 10 that had videos that had over 1,000 views or over 1,000 hits. We had to eliminate the death panels and Obamacare is Satan videos because there were quite a few of those. And then we had 42 videos with relevant content. And you can see we really did this like a systematic review. We had inclusion, we had exclusion criteria, and then we had abstraction tools for the videos that did finish, that we did collect and finish and review. Abstraction tools that took things like how often are patients talking, how often are family members talking, how often is it clinicians, is it upbeat, is it not, do they use music, what's the lighting like? We used to laugh and say we could make the very best horrible advanced care planning video based on everything that we saw. It would have like a flickering candle with an empty canoe going off into the sunset, fading away to a bedroom that's perfectly clean with an empty bed, and plaintive violin music. Like, we could make it. We saw them all. That would be a bad one. So you can see too the videos that we saw on YouTube, they came from everywhere. They came from individuals like Anthony Cirillo, I don't know who he is, but we watched his video. They came from groups and media groups like CBS. They came from academic institutions like Duke Medicine. Some of the most prominent ones came from the Canadian government, the Canadian Hospice and Palliative Care Association that was funded partially by the government. And then Hungry Beast was a very popular one, which I guess is the Australian equivalent of Dateline NBC. So I'm going to give you just a brief look at what one of the videos looked like, just so you get an idea of what we were looking at. You didn't get it, that was from a hospice in South Carolina. So I'm going to show you just briefly, this is one from the Canadian government. This is the one that we said looks like what we want to shoot for. And the content's not right. I'm going to only show you about 30 seconds of it, but when we started filming, we said this is our goal. We want to look something kind of like this. This is our ballpark range.
I would guess there's a big percentage of people who don't like to talk about it. And there's a big percentage of people that it happens suddenly, you never get a chance to talk about it.
Well, of course, we are from the age that things weren't talked about.
It's not part of, hey, what'd you have for supper last night?
You gotta know what to do, what you want done.
We have to talk about this. We should talk about it. So that when and if this happens, you get the care that you want.
We did cognitive interviewing with patients and families, post-operative ones on this. They were like, you'd see them nodding, they like this. This comes up and it says end of life care, and they would go, but I don't need end of life care. I'm just going for surgery. So yet again, this video was great until it said end of life care and such. Yet again, it's a really kind of narrow mark. It's a line we're skirting. We don't want to freak people out. We don't want to unnecessarily alarm people, but we do want to talk a bit about advanced care planning and how do we do that in an effective and yet non-threatening way. So this is one of the videos. So we actually then did an initial script, which we iteratively wrote. Our lead surgeon co-investigator, myself, and our lead patient family investigator, we wrote, and then we translated it into storyboards, and we worked with a medical illustrator that helped us mock up photographs and then some basic content. We had 12 storyboards, and we needed to really take this for a big round of patient and family engagement because we think we had kind of the content and some of the look of our video. And did we have it right? So we said, well, where can we find a bunch of people, especially a bunch of lay folks, lay public, because that's big for PCORI. Is there a big party going on? Oh wait, there is a big party, the State Fair. The State Fair is coming next month. So we got a booth at the Maryland State Fair in 2014. It was kind of like there were some jewelry salesmen on one side, some people selling furniture, candy folks, and us. It was actually very good because we were in the air-conditioned, it was very hot, we were in the air-conditioned hall, and so we had a lot of people who came in. And in honesty, we had 360 people who came in over 10 days. They spent an average of 9 minutes with our booth. The majority were older adults. We were surprised that only 20% of them had had cancer, but all of them had self-identified as either themselves having had surgery or having had a loved one who'd had major surgery. They reviewed our storyboards. As you can see, our storyboards are there. Those big white bowls are chocolate, so we, of course, enticed people with chocolate. And they did a de-identified survey, and they didn't realize that they did a preference modeling task to help us figure out our outcomes for our study so that we could better identify what outcomes they cared most about. And yet again, another conversation for another day. They completely changed the outcomes and how we're doing the RCT right now based on their input. And so we filmed and we cut the video. And that took months, and I'm not going to go into all the details of that, other than to say it took a long time. And we had versions of it that ran with about 70 different people over a period of engagement with, and that was with surgeons, with patients and families, just to try to get the tone right and everything. And I'm going to show you only about 2 minutes of the video, and that's because the video itself runs 6 minutes, and I don't want to take up all that time, but this will give you a bit of a flavor. And like I say, everything, the lack of music, the framing, who's in there, everything is in response to input that we got and our primary research before this.
Hello, my name is Theodora, and this is my sister Carolyn. She had surgery last year.
A video for patients and their loved ones.
Hi, my name is Judy, and my son had serious surgery.
Hi, I'm Matt Woods. I'm a surgeon.
Hi, my name is Rhonda. I've been an ICU nurse for 18 years.
I'm Rebecca Oslingson. I'm a doctor who performs anesthesia.
My name is Carolyn, and I had major surgery.
Hi, I'm Marty McCary, and I'm a surgeon.
Getting ready for major surgery. Advice from patients, family members, nurses, and doctors.
The surgery was my only shot at going into remission or being cured. And I knew I had to take this window of opportunity because my health was really good at the time.
Fast forward.
Period of time.
In the ICU, it's rather overwhelming. There are lots of alarms and beeps and many people that are trying to take care of your loved one, and sometimes you don't know who they are, but you know they're there to take care of them.
I woke up in the ICU, and my friends were around my bed, and the ICU nurse was standing over me.
It's my experience that frequently patients don't even remember their time in the intensive care unit.
In the ICU, my sister Carolyn was very, very sick, and she was heavily medicated and could not communicate for a couple of days.
In the operating room, in the ICU, I do not remember. I was hallucinating, I just don't remember.
Before you have surgery, clarify who makes decisions for you. Even when the president goes under anesthesia, the vice president's ready to make any decisions that need to be made. Your surgeon and surgical team will talk to you about the risks for your surgery. For example, this could include rare things like stroke, or a long hospital or intensive care unit stay, with you even depending for a while on machines for things like breathing or feeding, your loved one needs to be ready to speak for you in those rare circumstances. So be sure they know you. They are ready to talk about your beliefs and your goals and your values.
What I wish I had known prior to surgery was just to be prepared, to make sure that I had investigated all the possibilities and had conversations with my family prior to the surgery happening.
A little bit of planning before surgery can make a huge difference after surgery, not just for you, but for the people who care for you and the people who will be caring for you.
Look at her now. There was a
time. Close it off, so that's part of the video. Alrighty. So our RCT is ongoing right now. We're enrolling from 6 cancer surgeons, patient randomized to our video or a control video. The control video pretty much says, Hopkins, woohoo, great place to have surgery. Alston was here, yay. Which is funny. And we audio record conversations between the surgeon and the patient family as they discuss the risks and benefits of the surgery, because our hypothesis is that these videos are going to empower patients and families to maybe ask about things that they didn't ask about before with a different video. Our goal is to enroll 90 patients. We're currently at 30. I'm blinded. I can't tell you anything. I don't know how it's going. So I'll tell you more in a few months. Yet again, our team. This is a bit of an older photo, but like Judy on the top left is our lead patient family investigator. We've got lots of different people on the team. One of the things that's hard about this work is we started specifically as a pancreatic cancer study, and we had co-investigators who were pancreatic cancer patients, surgery patients, and fortunately 2 of our patient co-investigators have died during the process of the study because of their cancer coming back. And even though you prepare for it and you think, okay, I know this is going to happen, I'm going to be ready for it, it's still hard because it takes us, it's hard because these are people we know and we care about and they're part of our team. And then it's also hard too because you can't replace them. And even when we bring somebody new onto the team, they don't know what went on before. And it takes us about 5 months to onboard a patient family advocate who's a co-investigator. So although you know that's something that happens when you do this type of work, it doesn't make it easy. So considering anything a career in academic palliative care and cancer research, let me just say that the road is windy. If you had said, Rebecca, you're going to be doing, a booth at the state fair and you're going to do a systematic review of YouTube, I would have thought you were crazy. But it was the right thing to do for the study, and it was the right thing to explore some of the questions we were trying to explore. Warning, fasten bra straps and remove dentures, very bumpy road. I didn't even go into, but certainly any big study has bumps and problems and things you didn't foresee. I could go into it. Legal, make a video. You get to meet the legal department. It's a joy. We're still close companions. But yeah, time flies when you're having fun. And things that may sometimes seem a little bit like odd fellows, like perioperative care, surgery, cancer care, palliative care, actually makes for really fun and interesting research. So I want to thank Norma, of course, for inviting me, as well as Elizabeth Platts, as I started with. I'm going to finish with, and thank Tom. That's it. Any questions I fully look forward to and I'm happy to take.
So we have time for questions from the audience.
Gosh, it was that good.
Well, for me, it was a brand new topic area, not something I'm familiar with. But I do know that the Maryland Cancer Plan has highlighted palliative care and survivor care. And so it's very important, and I think the focus on patient-centered outcomes is really, the twist, if you will, that will make the video very useful.
I hope so, and one of the things too is the field has changed. When we proposed doing this, so we wrote this grant in 2012, so that's only almost 4 years ago now? 3 years ago. And to do advanced care planning in the perioperative world and the perioperative cancer world, people were not into that. People couldn't believe we had surgeons who were willing to get on board with us with this and that we could do it. And we had people who said, you absolutely can. And I gotta say, the palliative care field and palliative care research has grown exponentially since then, and our grants right now are taking this and saying, this is great, advanced care planning, but let's do full-op perioperative palliative care. Let's send some of these patients before their major cancer surgery to see the palliative care team, to have surgeon and palliative care team co-management of symptoms and perioperative psychosocial support of the patients and families, with patients and families following up post-operatively with their surgeon as well as with the palliative care team. People couldn't conceive of that a few years ago, and we're writing grants on it right now, and I have surgeons lining up to participate with me on these trials. So it's a different field. It's rapidly changing. It's very exciting. But boy, yeah, this was the cutting edge 3 years ago, and we're still kind of the cutting edge, but the field's gone. It's gone even beyond this.
Yeah.
Okay.
What outcomes are you measuring in your RCT?
Oh, that's a great question. So we had originally, so Claire asked what outcomes, questionnaire asked what outcomes are we measuring in our RCT. So we had originally written and powered the RCT around hospital anxiety and depression score of patients, specifically saying that we thought this video was going to decrease their anxiety and depression around the time of surgery. And we had good preliminary data that those scores peak at very high levels at the time of surgery. So we thought that we'd be able to have some good discrimination in that. And then, as I said with the state fair, we had patients and families rank outcomes. Like, we could measure many things with this video. Here are 12 different things we could measure, and those items were things that we had gotten from previous trials. Remember the systematic review? Those were outcomes from that systematic review that had been used in other trials. And we said, if we can only do 5, choose the 5 that you think are important. And they had 12 choices. And anxiety and depression scores came in last. Came in number 12 of 12. And when we went back, and we were shocked, we were very surprised. I was actually on vacation at the time, and my co-I called and said, Rebecca, are you sitting down? And I said, John, why do I need to be sitting down? He's like, our primary outcome came in last. And when we went back and did qualitative with patients and families, they said, I don't care what video you show me, I'm going to be anxious around the time of surgery. I have no expectation of that changing, and I don't expect it to change. It doesn't matter to me because it's never going to get less. So then we went and looked, and the thing that came in first was, and it was a very, very clear first, was patients and families thought this video would be a success if it enabled them to have a conversation with their doctor about their goals and wishes. So we said, okay, conversation. We've got to measure the conversation, and that was problematic for a number of reasons. First off, that threw us a little bit into qualitative land, and that's just a different land to live in. I've done a fair amount of qualitative work in the past, but to think of doing a large RCT with a qualitative outcome is intimidating. And then also, 2, it meant that we had to capture data somehow before surgery. So first, we had already been reaching out to Deborah Roeder, who's a distinguished professor at the School of Public Health who has spent a career studying patient-provider communication, and she has a score, the RIAS tool, Roeder Interactive Analysis Score, which essentially takes qualitative data and makes it kind of quantitative, and it's a well-validated metric that can measure things like the patient-centeredness of conversation, as well as empathy and patient activation, so that was what we were interested in measuring and doing. So we went and knocked on Deborah Roeder's door, who happily came onto the project. And then also we had to really sit and talk with our surgeons, because now we needed to measure a conversation, and what conversation were we going to measure? So while this won't be the way that the video is used in real life, we need to be able to enroll patients, so they need to see their surgeon first. So they currently see their surgeon. Their surgeon mentions the study. If they agree to enroll, we approach them. Well, we approach them, they agree to enroll, sign written informed consent, they get the video. They then go home, they have web links to the video that they're signed to. They can watch it whenever. They can watch it on any device that accesses the web, smartphones, tablets, computers, Apple TVs, whatever. Anything that accesses the web, they can use it to watch the video. It's password protected, because it shouldn't be out in the general public yet. And then they go back and we audio record when they sign surgical consent with their surgeon. And that's what surgeons, the audio record the conversations. But that's our primary outcome, is that conversation. We're still measuring hospital anxiety and depression scores. We're also measuring Iowa criteria, which is why people seek out medical care. We're also measuring consensus between patients, family members, and surgeons. Specifically about how they think that conversation went. And what the PhD student on our project, Serena Eisenberg, who's absolutely fabulous for her dissertation, is studying the role of family members in these conversations.
Oh, Rebecca,
That's it.
with the flashing lights.
Woo!